Okay, so this is the lecture scheduled for the 12th of November, which we had to finish halfway through. I will go through the first part of the lecture quite quickly and then focus on the second part, which you haven't heard yet. First, it's very important to be clear about the terms we use in oral medicine and talking about oral mucosal lesions. So when we talk about atrophy, it's just thinning and wasting of the epithelium, and it can be physiological in elderly, can have multiple other causes, including radiotherapy or medications. Also to be remembered that chronically moist skin becomes atrophic, as here. But also iron deficiency, like in this patient with undiagnosed celiac disease and Sjögren's syndrome, you can see the atrophy of the skin at the corners of the mouth. Erosion, on the other hand, is basically loss of epithelium. It's superficial, heals without scarring, and can be caused by chemical, mechanical, or immunological causes. Ulcers are deeper than erosion, and epithelial necrosis is typically in the background. It can be caused by infection, chemical injury, immunological reactions, or malignancy. Aphthous ulcer is commonly seen, probably in all of you, you know what we're talking about. Nothing sinister about these common finding. Unless you have multiple aphthous ulcers at the same time, you may need to start thinking of systemic causes for ulceration, such as Behçet's disease. Oral lichen planus is the most common skin disease, skin condition seen in the oral cavity, and has its erosive forms, and this is a typical finding of that, as well as here. These lesions look very similar, but are caused by a systemic disease called systemic lupus erythematosus, SLE, and by eye you cannot tell one from another. Vesicles, on the other hand, are basically full fluid-filled blisters and can be intra or subepithelial. They rupture in the oral cavity very easily, and typically what you see is not a blister, you see an ulcer. In the skin, the blisters remain blisters. Skin is tougher and less moist, whereas in the oral cavity, similar disease, similar pathology shows as just a large ulceration like here. But blistering and ulcers can be caused by systemic spread of infections such as syphilis here, and ulcers can also be caused by malignancy. So there are lists which will be introduced to you repeatedly over the years of the differential diagnosis of oral ulcers. This is just one of those lists. Similarly, there are differential diagnoses for oral blisters. The point what we do today is to understand that what we see clinically, an ulcer lesion in the oral cavity, the etiology can be anything ranging from immunological background, microbiological infection. It can be a pathology. It can be just variation of normal anatomy. It can be caused by trauma, by biting your lip, mechanical trauma, or chemicals or physical exposure to, for example, very hot food. It can be a drug side effect. Therefore, when you're looking at these lesions, it's very important to take the patient history very carefully, think of the clinical picture, do what you need to, take a biopsy, do the microbiology, possibly look into immunology, and only with all this information you are able to make your diagnosis and plan appropriate treatment. So how do we judge if there is something funny going on with the patient's immune system? Immune system has three main functions, which infection control is the most important one. It's also very important that whilst controlling infection, there is tolerance. the immune system should not respond overly to the presence of normal flora at normal sites. Also, the immune system is responsible of clearing altered autologous cells. Practically, this means virus-infected cells or malignant cells. Typically, what we see if something is different in the patient's immune system, we don't see that one of those arms goes wrong. Patient typically does just not have infections, but typically has, in addition to maybe having a higher susceptibility to infections, also may have autoimmune diseases, autoimmune conditions, or allergies. And the same patient is more prone to malignancy. And these are, it's not that allergy would cause infections or infections would cause allergy. They both have the same background factor, which sometimes can be found out what it is, but many times we don't know what the true reason behind the problems patient has is. So oral cavity is quite different from many other places in the human body. So there are some special features, and one of them obviously is rich normal flora. And there are, in addition to the bacterial antigens, there is a broad spectrum of other antigens, all the food and other things we put into our mouths. There is a spectrum of immune responses. Basically all components of the human immune system are presented there, and there is a lot of tolerance going on. If the oral mucosa responded as aggressively as for example lung mucosa, we would have severe inflammation in our mouths all the time. It is a very common route for infection and a place for natural immunization. The oral cavity tolerates well its normal flora, and the amount of microbes is kept under control in a very sophisticated manner, avoiding unnecessary inflammation or threat to self. Normal flora stimulates and provides appropriate stimuli for the adaptive immunity, and the question is, where is the human immune system then located? Where does it come from? There are a number of organs and tissues that work in concert together to form and restrict the immune responses just listed here. But the question about the human immune system really is that its activation should be targeted right. It should be clearly against non-self, not self. The bystanders should be protected, and the activation should be appropriate. It should be enough, and we should be able to stop it. Therefore, any problem in this communication between the components of the immune system can cause a lot of trouble. The components of the human immune system are basically innate immunity. In general, we say that it's sort of general defense mechanism and is based on pattern recognition molecules, typically the complement system or toll-like receptors. There are cellular components as well as phagocytes that polymorph neutrophils and monocyte, macrophage, dendritic cell line cells are. Innate immunity is capable of inflammation as well, and mast cells and complement system are very important here. Then, of course, as vertebrates, we have also adaptive immunity, cells that come from bone marrow, and mainly the main components are B cells and T cells. B cells responsible of antibody production, and T cells of cytokine production. Cytokines mainly responsible of inflammation and attraction of phagocytes. This is the busy picture, but very simple. On the left-hand side here we see innate immune system, and on the right-hand side adaptive or acquired immune system. The top boxes are about your humoral components, and in the bottom we see cellular components. How the human immune response normally starts, if you haven't been exposed to the new antigen before, complement system is capable of recognizing non-self material and leading to opsonization of that material. It can also cause direct lysis of bacteria, and then those cells that are opsonized can be phagocytosed by the polymorphs or mast cells, and these are just phagocytosing to clear the mess, whereas monocyte, macrophage, dendritic cell line cells are so-called professional phagocytes capable of antigen presentation, basically presenting antigens of those ingested microbes to B cells and T cells, enabling plasma cell production and specific antibody production, which again can start complement activation. So all the components of the immune system work in concert. In the acute phase, it's the innate immunity which is active in tissues. We see complement activation, we see a lot of PMNs, whereas we go to chronic tissue inflammation in tissue, we see more lymphocytes and can have antibody accumulation. So in summary, they operate in concert and they share responsibilities, they modify each other, and in general we say that innate immune system is faster, it does not require previous contact, it's a bit narrow in its spectrum, depends on the pattern recognition, whereas adaptive immune system is slower, it's more specific, but it can respond to broader spectrum of things, and it develops memory and becomes intensified. The broad spectrum of the adaptive immune system can be a problem, as immune system can also learn wrong things and start responding to wrong antigens and cause autoimmune diseases. So first, go through a little bit of the human complement system. I understood this is you're not that common, familiar with the human complement system. So the complement system generally has a couple of main functions, and generally it's seen that opsonization, basically marking something for phagocytes, that phagocytes can come and eat away, is very important. And it's basically the only way that phagocytes can phagocytose something without antibodies. And this is crucial in the case of first exposure and in altered autologous cells where we don't want host responses. It's capable of direct killing of cells, cytolysis, but this only works on gram-negative bacteria and host cells, virus-infected host cells, and malignant cells. It's definitely capable of inflammation, and the complement activation pathways lead to production of chemotaxins and anaphylotoxins. It's also important in immunocomplex processing, basically antibody-antigen complexes, circulating complexes, and saving the kidneys from becoming totally overloaded with them. You don't need to know every component of the complement pathways, just sort of summary that complement cascade, as it's one of the cascades in the human body, just like blood clotting, consisting of over 20 molecules that one activates the other one, and on it goes. There are different ways where the activation can start. It can be the antigen-antibody complex in the beginning. It can be C-reactive protein bound to a bacterium that starts the activation. It can be certain microbial structures like mannose sugars, which are not typical for human cells, that started. Mannose sugar is typical for fungi. And but interestingly, actually, there is so-called alternative pathway, and that means that complement system is active at all times. And basically, the only way that where the recognition is actually by the activity of so-called inhibitors. So complement would kill every human cell if allowed by lack of inhibitors. But nevertheless, it leads to chemotaxis and lysis in gram-negative cells. So this is just a 3D image of the same. Here, having some foreign structures under the antibodies bound to them, two antibodies bound close enough to each other so that the first complement component C1q can bind to the two FCNs, and then that triggers the activation of the components and the formation of the final lytic terminal complex. And all these components up in the fluid phase are chemotaxins and anaphylotoxins. This is just a summary of what complement can do and will do given half the chance. So it has impact on a number of cells. It's very important in sepsis and in other rapid reactions, and it causes very broad spectrum of different inflammatory responses. Okay, so what cells are then involved in phagocytosis? First of all, we have our mononuclear macrophages, which can hide in tissues for years, and then inflammatory mediators such as complement activation can activate them and then start producing all sorts of cytokines. PMNs, polymorphic neutrophils, can circulate. They typically circulate in blood until attracted into tissues. So that's the blood is the reserve for PMNs, whereas tissues are the reserve for macrophages. What happens in phagocytosis? First, the cells have to be attracted to the site of infection. So if we talk about PMNs, they circulate in blood, and if there is an infection in tissue, they have to leave the blood vessels and get into the tissue to do their job. So for that, they have to be attracted there, and that's done by chemotaxis, chemotactic complement components, or some cytokines. Then that at that site, something has to opsonize the foreign body, the bacterium, for the phagocyte to know that it's something that it can eat. Typically done by complement or antibodies, as said already. There has to be a specific mechanism for the recognition of these opsonins. So there are complement receptors and so-called FC receptors on phagocytes. Then this meeting of the phagocyte with the opsonized cell has to lead to activation, and then only after activation has taken place, the cell engulfs the microbe and then degrades it away. So this is just a picture of the same, basically opsonized bacterium binding to its specific receptors on the macrophage, and then engulfed, degraded, and often then that leads to cytokine production. So we go to the other corner of the cellular immunity, the lymphocyte side. So there are billions of lymphocytes in blood at every moment, and there is a constant circulation between lymphatic tissues and blood. And they all originate from bone marrow. T cells mature in thymus and B cells in bone marrow. And maturation, what we mean by maturation, it's basically gene recombination. It means that it can lead to receptors that can vary from each other. We have millions and millions of different receptors because of gene recombination. Maturation also means that there has to be so-called positive and negative selection, and this selection is done by MHC and autologous peptides, basically checking that the cells and the receptors on the cell bind tightly to what they should bind to, and do not bind to host cells. And then there needs to be central and peripheral tolerance, and that's basically defined by the maturation. Antigen presentation is important. That's really the clue between crosstalk of innate and adaptive immunity. The first step is you have to have the antigen presenting cell. So these are the professionals: monocyte, macrophage, dendritic cell. Some lymphocytes can do it. The presentation takes place in a tray or in a locus, what we call the MHC, major histocompatibility complex, which we have class 1 and 2. Class 2 is on mobile cells like macrophages, and they're capable of endocytosis, and then they present the peptide, the bit of the microbe that they want to lymphatic tissues and cells. MHC1, on the other hand, is basically on the inner surface of most cells, and if there is an intracellular microbe, it binds to the class 1 inside the cell, which leads to flip over and presentation outside the cell, causing attraction by cells to kill that target. So all this work that we talk about MHCs has been done with mice, and our knowledge about how the human immune system really works is really based on animal work. In humans, we don't talk about MHC, we call them the same structure: human leukocyte antigen, HLA. So MHC1 is HLA1, and MHC2 is HLA2. HLA1 has subclasses A, B, and C, and HLA2 subclasses DR and DQ. So these are just subclasses of trays to present antigens to T and B cells. And there are various haplotypes that have role in infection control and also autoimmune diseases. For example, HLA1 DR and DQ, HLA2 DR and DQ have been linked with a number of autoimmune diseases, and HLA-B27 class 1 is, for example, with ankylosing spondylitis. So a problem in what is presented to your T and B cells, innate cell side problem leads to autoimmune diseases. T lymphocytes, on the other hand, when they get mature and circulating, their main function really is to regulate the immune responses by production of cytokines. And that's especially the job of CD4 T helper cells, we divide them Th1 and Th2 classes depending on their response to and production of IL-4. So Th1 leads to cell-mediated responses and response to intracellular pathogens and autoimmunity, and interferon gamma is there important, whereas Th2 cells are so-called antibody dependent and respond to bacterial infections and are linked to allergies, and IL-4 and IL-10 important there. And T cells are also in charge of clearing altered autologous cells. Then finally, B cells are the ones producing antibodies and helping the cycle to start over. CD8 positive T killer cells are specific kind of T cell that are especially targeted of killing infected or altered autologous cells directly. Cytokines are really hormones of the human immune system. They are intercellular messenger molecules, and many cells produce them, but T cells and macrophages are the professional ones and are essential in this. Every cytokine is made by a mixture of cell types, and cytokines are highly inducible. And the effects are primarily local, unless so much is made that you start get systemic effects like in sepsis. And once a cytokine binds to its receptor on a target cell, it sets off a signaling cascade and alteration of gene transcription in the target cell, defining the biological effects of that cytokine. This is just one of those lists you can find from textbooks, but really showing that there are a number of different types of cytokines, and really the outcome, what the production of these cytokines leads to, depends which sort of patterns are, what the sum effect of all these are. And it can lead either to anti-inflammatory or pro-inflammatory side. And of course, some of these inhibitors are being used to treat inflammatory diseases. Natural killer cells is finally the last type of T cells that may be of importance for in dentistry, and it actually kills by surface contact, like here, and has been linked to clearing of malignant cells especially. And yeah, there are papers going into detail how this communication is done and how the NK cell kills tumor cells. Not the topic of today, but just to let you know that actually these mechanisms are quite well understood today. So what are the prerequisites of the immune response? So the body must produce a protein capable of recognizing the foreign structure, and this protein must bind strongly to the structure. It's not good enough that you produce something which is not binding properly. And there must be effector cells that recognize this structure-bound protein, not the loose one, but once it's bound to the structure it should bind to. And recognition should lead to activation. So there are a number of steps here which can actually go right or go wrong. Okay, so if we talk about how immune responses can mediate tissue damage, one way of doing it is, of course, that there is immune deficiency, so the body does not protect itself against infection, whereby you get damage caused by invasion by microbes. This can be primary or secondary. Primary meaning that you were born with it, and secondary that you had acquired it. On the other hand, the damage can be also caused by hypersensitivity. If your immune system is overly active, and you get bystander damage. And then there is a question: can we modulate these two ends? So hypersensitivity, first of all, we normally talk about what it refers to is excessive, undesirable, damaging reaction produced by the normal immune system. Hypersensitivity reactions require pre-sensitization, so we talk about immune state. And hypersensitivity reactions are normally divided into 4 types. Type 1, 2, 3, and 4, based on the mechanisms involved and time taken for the reaction. So hypersensitivity reactions are actually the most important part of immunology for anybody in medicine to understand. Immune deficiencies can be dealt with, and then you just treat the infections and control the damage. But the immunological side of the hypersensitivity side of damage is challenging, and these are the patients which are probably during your working time going to be treated quite differently from today. yes, finally, hypersensitivity is frequently a particular clinical condition or disease, but involves more than one type of reaction. This is just another textbook picture of all the 4 types and what the mechanism behind it, what is the antigen they respond to, and what is the reactant, and examples of diseases linked with it. And I will give examples. These are, of course, textbook examples, more sort of medical side examples, but I'll be giving you some oral examples of all these. So first, type 1 is what we call, in lay terms, allergy or anaphylaxis. So it's generally mediated by IgE, and it's the primary cellular component is mast cell or basophil, and the reaction is amplified and or modified by platelets, neutrophils, and eosinophils. And it's very rapid, 15 to 30 minutes, response to an antigen, which is typically a non-self particle. So it's really depends that you have to have a plasma cell with after the first exposure, the plasma cell produces these IgE molecules plasma cells produce IgE molecules which bind to mast cells, and they are there already. The mast cells that circulate in the host are covered with IgE. And when second time the person meets the antigen, it can be like here ragweed or it can be penicillin, the molecule cross-links the 2 arms of those IgE antibodies, leading to immediate release of chemicals and the symptoms. So the first exposure takes time and requires IgE production, but second time around it happens immediately. If you are atopic kind and you have these cells with IgE on them circulating, it is possible that exercise and emotional stress chemicals, all sorts of things, actually also may trigger mast cells. It's more common with patients who have IgE, but actually you don't even need to have IgE on mast cells. Enough strong stress, damage, tissue damage, you get the release of the chemicals without any IgE. So this is basically just the same picture and just summarizing what the release of the primary and secondary mediators can lead to. What we know that in allergy is seen swelling and dilating of blood vessels, as well as bronchospasm and so forth. Really, the first symptoms occur within minutes and recurrence may follow hours later, so-called late-stage response. So anaphylaxis can only occur in an individual previously sensitized to an allergen, as its initial exposure causes immunoglobulin E to bind mast cells, as said already. As I said, yes, you can get the plasma cells to release their contents by extreme damage to the cell or trauma, but that's not typically the case. And we categorize them either as local or systemic, and local anaphylactic reaction are hay fever, hives, and allergic gastroenteritis, whereas systemic anaphylaxis produces peripheral vasodilation, bronchospasm, and laryngeal edema. And they may involve basically any tissues, but typically skin, eyes, nasopharynx, bronchopulmonary tissues, and GI tract. Type 2 hypersensitivity, we call it also cytotoxic or antibody-mediated or antibody-dependent hypersensitivity. And these are antibodies directed against normal or modified cell surface or tissue components that induce cell lysis. So it causes direct lysis by complement activation. And monocytes and neutrophils, eosinophils or NK cells recognize cells by their Fc portion and of the IgG bound to the cell and kill cell without phagocytosis. So it's, what we can summarize it is that it's a normal IgG or IgM mediated response to cell structures. So it would be normal if it was against the microbe, but unfortunately it's against cell structures, whereby you lead to damage. Reaction can come in minutes or hours. It can be continuous on slow rate. And the examples of this disease can be autoimmune hemolytic anemia. Certain drug reactions are in this category, or pemphigus, where the antibody is against our catetrins or desmosomes. Pemphigus here is an autoimmune disease against desmosomes. You've been hopefully in histology, pathology, explained a bit of the epithelial structure, but it leads to basically intraepidermal blisters and extensive erosions, apparently healthy skin and mucous membranes. So they are intraepidermal blisters, and autoantibodies are directed against specific structure, desmocline 1 and 3, and the autoantibodies can be seen in pathology stains, and any area of the squamous epithelium can be affected, including mucosal surfaces. Pemphigoid is a different version of the same. It's very uncommon, just like pemphigus, blistering skin disease, and in this disease the autoimmune response is against hemidesmosomes. So you may remember that desmosomes bind epithelial cells to each other, whereas hemidesmosomes bind the epithelium to the basement membrane. So although you might think that this is more serious, the whole epithelium may fall off, it actually has better prognosis than pemphigus. And it is known exactly how it works and where the antibodies and the destruction takes place, and how the epithelium blistering happens underneath. So these were two diseases. A third disease, which is a good example of type 2, is hypersensitivity, is erythema multiforme, which can be minor or major also called Stevens-Johnson syndrome, and just destruction of mucosa. It's a very strong immunological reaction, similarly to the previous ones, against some foreign antigen, typically foreign. It can be herpes simplex, it can be mycoplasma, or some medicine, like in Stevens-Johnson's often it's for example clindamycin. But in most cases we don't know what causes it, and unfortunately, because we don't know what causes it, patients get recurrences because they can't avoid it. Okay, so those are examples of type 2 in the oral cavity. Type 3 hypersensitivity, also called immune complex mediated or complement mediated hypersensitivity, is basically caused antigen and antibody complexes, which cause tissue damage by activation of primarily complement. So as I mentioned already when we talked about complement is very important in processing these antigen antibody complexes, and this just should be taking place in somewhere safe and not causing damage to host. If these complexes are deposited in the tissues, and complement activation starts there, it's a strong inflammatory reaction, and can cause systemic symptoms like fever, broad areas of urticaria, arthralgias, and so forth. Normally the reaction time is 3 to 10 hours. typically the antigen, what they respond to is exogenous. It could be a bacterial antigen, it could be some endogenous antigen, like in SLE. Neutrophils and platelets mostly are responsible for the tissue destruction, activated and attracted to the site by complement. And inflammation in and around the vessels cause acute necrotizing vasculitis and fibrinoid deposition and acute inflammation. And really the classical examples are reactive arthritis and SLE. This is just the same picture as earlier of SLE, which is really an autoimmune disease where you have antibodies. It's very typically localized. It's can be also systemic, and you have white striae, erythema, ulcers, and scarring, and minor symptoms. Generally, it's necrotic, so it's not ulceration, painful ulceration as such. It is a pre-malignant condition. These are lesions on the skin and in the oral cavity. So that's an example of type 3 in the oral cavity. Then we have type 4 finally, which is called cell-mediated or delayed hypersensitive reaction, and we talk about delayed T-cell mediated reactions here, where the T helpers type 1 cells secrete cytokines which activate the cytotoxic T cells and recruit and activate monocytes and macrophages, causing most of the damage. So it's really to do with the cytotoxic T cells. Antigen is typically a microbial structure, but typically a chronic microbial. So it's been described for TB, but can happen also in periodontitis. But it can be also chemicals and metals and dyes and amalgam, metal fillings and structures in the oral cavity can be cause for it. And it leads to formation of granulomas, which we also see in periodontal disease. So it's involved in the pathogenesis of many infectious diseases, and major lymphokines involved are listed here. Maybe not that exciting for you, but just to remind you that we know quite well the mechanisms, and knowing those mechanisms can allow us to develop more targeted treatment for these diseases, including periodontitis. Reaction typically can be seen within 24 hours, so that's quite slow already. And if you get rid of the antigen, it disappears within a couple of days. The granulomas develop more slowly, in weeks or so, and do not disappear easily unless you get rid of the cause. So this is just another table of summarizing all these, and I think it's very important for you to, at this stage, think of the tissue destruction mechanisms that we look at in the oral cavity with a bit of thought what the immunological basis of all those are, because more and more modern treatments are coming for these diseases, and we're not going to be using steroid creams for everybody in 10 years' time. So to be able to understand why certain treatments are applicable to your patients is based on understanding the biology behind it. There are a couple of very good reviews on this, for example, on already these new drugs that are being developed. Nature Reviews Drug Discovery journal, number of similar reviews you can find to look into how you try to avoid bad things happening. So that was all I had to say today, and I hope you find this clarifying to the topic, and you understand why these immunological mechanisms were discussed today. If you have any further questions, I'm happy to answer them. You can email me using the university email address. And maybe this slide set is something that you might like to dig out later on in your studies when you start tackling oral medicine. The slide set will be put on Blackboard. Okay, thank you very much.